Thank you for thinking of me when you were looking for somebody to share this topic with you. Um, I don't take it for granted at all. So I'm very honored to be here, honored to share what I know, what I've learned, and what, my own results are with my own patients. So as the theme of the program was, it's about perimenopause and menopause. What's going on during this phase, what to expect, how to feel, all the important details that we want to know about. Um, as Sister Elizabeth said, I trained in obstetrics and gynecology. So I'm board certified in obstetrics and gynecology, and I've been practicing for 7 years now. On my own, on my own, meaning my own private practice. So I was working for somebody before in a private practice before, and I was doing obstetrics, meaning I was delivering babies, and gynecology, so I was in the women's health outside of pregnancy part. But I thrived more in the women's health outside of pregnancy part and surgery. But there wasn't any jobs out there that would let you just do that, especially in the area that I wanted to live in. I wanted to live in the Chicago area. A lot of people wanted both obstetrics and gynecology. So, as God will have it, I just had the inspiration that, okay, if you can't find what you're looking for, you create it. So that's how I created my own private practice where I mostly do women's health outside of pregnancy. So everything that is happening to women that does not really have to do with prenatal care, I handle. So that's how I got really, really into menopause and perimenopause, because if you're not delivering babies, you're seeing women who are not having children or women who are done having children and managing the issues that those women are going through. And so in the last 3 years, I've had a lot of experience, a lot of exposure to perimenopausal women or menopausal women or postmenopausal women. And I've been able to expand my repertoire in helping them. So we can go right into the topic, perimenopause. Let's see. Yeah. So what is perimenopause or menopause? Menopause means menses pause. In general terms, it means menses stop, really. Uh, and so the diagnosis of menopause is you go 12 consecutive months without a period. So if you go 1 month with a period and then you skip 2 months, then you start again, you're not yet fully in menopause. You have to go 12 months back to back without a period. That's when you're in menopause. But the problem is that menopause is not just the period stopping. Menopause really is the ovaries, the eggs in the ovaries declining. And I'll get there because it's important. So because you're gonna have menopause-like symptoms and still be having periods. Those are the perimenopause. When peri means near menopause. So you have women who are still having monthly periods, or their periods are becoming irregular, but they're feeling as if something is wrong. They feel like they're getting older. They feel like they're in their 70s or 80s. Why do I feel this way? I'm still having periods. I know I'm not in menopause. Why am I having this symptom? So those are the perimenopause women. And then the women who have gone 12 months back to back without a period, those are the menopausal women. And women maybe who have been in menopause for a long time, they are post-menopausal women. Now, that transition from perimenopause to menopause can last up to 10 years. So that's what's frustrating about it, is that you are not in menopause, you're still having periods, maybe they're becoming irregular, but you're having all the symptoms of menopause. And people always ask me, so when will it end? When will it stop? Um, the process is the ovaries are declining over time. And so it's not just a one day the ovaries stop. There's a gradual decline. And so that's why it's a year long, not a year, it's years long process. And like I said here, it comes with a lot of baggage. It comes with a whole host of symptoms that people do not even associate with menopause. And that's what's interesting about it. People have gone to see the sleep doctor, they've gone to see the cardiologist, They've gone to their PCP, primary doctor, the general doctor. They've gone to all these other doctors, and everybody's treating one symptom or the other, but nobody's bringing it all together as under one umbrella called menopause or perimenopause. So that's what we'll talk about today. So you can identify what you might be experiencing and determine if you are, if this is similar to what you're going through. And then I hear this a lot. Nobody told me it would be this tough. Like, my mom never had this they will have conversations about periods with you, your sisters or your friends or my, ladies, my patients would say, my ladies, we talk about everything else. We talk about pregnancy, we talk about our periods, but nobody's talking about this perimenopause, menopause part. So a lot of women are not aware about how disruptive it can be to their lives, how overwhelming it can actually be, these particular symptoms. So let's go into it. So the normal process is this. I'll use my mouse. I hope you can see my mouse to kind of describe. This is the uterus here. This is the vaginal environment, uterus, tube and ovary. Another tube on this side and the other ovary on this side. These eggs in here are called follicles. That's our eggs are called follicles. And there is a follicle stimulating hormone, FSH, that the brain will release to the ovary to tell it to grow an egg, grow a mature egg. So that FSH is a signal hormone going to the ovary to say, okay, it's time to grow an egg. Then the ovary will grow an egg. It takes about 2 weeks for that to happen. And then the ovary, once it's mature, will release the egg. So that's the released egg. The released egg will stay inside the fallopian tube. So the brain tells the ovary time to make an egg. 2 weeks period for the ovary to grow the egg. Once the egg is fully matured, about that 2 weeks, depending on people's cycle, the egg will be released by the ovary. When the egg is released by the ovary, it's called ovulation. A lot of people might know this from if they're still having periods where they're ovulating, one side or the other is hurting, either the left side or the right side, depending on which ovary you ovulate from, is the side that you release the egg from. When you release that egg, estrogen is very high, lots and lots of estrogen. And the estrogen will go and stimulate the tissue inside the uterus, inside the cavity of the uterus, and so build it up with blood. If a woman is sexually active in a relationship, marriage, wanting to get pregnant, sperm inside the vaginal environment will travel through the vaginal environment, through the uterus, through the tube to meet the egg to fertilize the egg. Once the egg is fertilized, then the fertilized embryo will travel back through the tube inside the uterus to become a pregnancy. If there's no sperm around, the egg will stay there for like 36 hours. So women who might have gone through fertility treatments might know this when they're telling them ovulation kits, when you ovulate, monitoring things like that. And so if there's no sperm around in the vagina, the egg that is there will stay maybe 36 hours and then it disappears. The body just disappears the egg. Basically reabsorbs the egg is the right term, but for my patients to understand, I tell them the egg goes away, it disappears. That, once the egg goes away, that's the signal for you to have a period. So each month, if you're not on birth control or anything, your ovary is growing an egg, releasing the egg. If the egg is not fertilized, you're having a period. As we get older, the number of eggs in the ovaries decline. Remember, I said it's an ovary decline issue. As the eggs decline, there's the brain is now having to send more FSH. It's now having to do more work to get the ovary to grow an egg. The ovary don't have as many eggs to grow anymore because as women get older, the eggs in the ovary start to grow old or go away. And so FSH, that is normally maybe between 3 and 10. Let's say I do a blood test, your FSH number is between 3 and 10. That means your ovaries have enough eggs and you only need FSH of 3 to get the eggs to release. Now, as the eggs decline, you're needing FSH of 10, FSH of 25 to even get the ovaries to release an egg. So, like I said, egg development leads to hormone release. That's what we talked about here. If there's no fertilization, you have a period. Egg decline leads to less ovulation, less periods, more FSH. So the brain is thinking, ovaries, give me some estrogen, give me some eggs. The ovaries are like, I don't have anything to give you, or I only have this much to give you. And so high FSH is what causes most of the menopause related symptoms that women complain about. So on average, when a woman comes to me complaining of all the symptoms that we'll talk about that I think is menopause related, the first thing I check is what's your FSH level? And most women, it's 50. There are women who are 105. FSH that is normally 3 or 5. You now see an FSH of 105 because the brain is pounding out FSH trying to get some type of estrogen from the body. So when you see a woman who is sweating like this lady in our picture, it's because of FSH. FSH causes dysregulation of the body temperature. So that's the side effect of having too much FSH. When you had enough estrogen, you didn't need that much FSH for your body to get the engine going, the ovary release, the eggs release, and stuff like that. But now the ovaries don't have much to give, so the FSH is sky high. Then you're hot, you're cold. My patients describe it as almost like fire. I've heard a patient describe it as fire before, starting from her neck up to her face, like a heat. It's like one of my patients said she feels like she wants to go and put her head in a freezer to cool down the heat. And then you're taking, or one of my patients is a nurse practitioner who goes to people's homes. And she'll be in the middle of patient care and she'll start sweating. And the patients will start asking, are you okay? Is everything okay with you? And she has to like excuse herself. Some patients take a change of clothes to work because everything might be drenched while at work. So that's how disruptive high FSH hot flashes, sweating can be. But FSH doesn't just cause hot flashes and sweating. There's this sleep problem. Some people, they're waking up several times because they're drenched in sweat and they're asleep. Waking up several times to change their clothes, or they're cold and they put the covers on. Then they're super hot, they put the covers up. So the sleep is just disrupted. They're not able to get a full night's rest. Women are irritable. They find that they don't have as much capacity that they used to. They're not as patient. Things that don't usually get to them start getting to them. They don't want to hang around people. They want to be, I hear a lot of, I just want to be left alone. I don't want to be bothered. I just want to go to work, go home, and not be bothered by anybody. And it translates to their children and their husbands and their partners. They start noticing they don't want to really hang out with their partners. They don't have enough patience for their children, and their family members are starting to say something is wrong. You're angry all the time. You're grumpy all the time. Starting to affect relationships. They might be saying it's in passing, but it begins to affect the woman. She starts feeling like something is wrong with me. I'm changing. This is not me. I don't feel like myself. I hear that a lot. How about concentration? There's this thing called brain fog. You go into a room, you wanted to pick up something, you can't remember why you went in there. Or you're in the middle. There was a patient of mine, she said she's in the middle of a meeting, in the middle of a conversation, in a meeting, and she loses a train of thought and she cannot get it back. So, these things might be like, oh, yes, sometimes I forget what I want to do, but they can be disruptive and really negatively impact the quality of work. I had a patient who was a banker, started forgetting financial transactions. That was when she's like, I need to do something. Because some people start to maybe think, maybe I need to retire early. Maybe I'm getting old. I'm not as quick as my job, when it's just menopause, right? How about body aches? People feel like I'm just achy all over. My joints ache. I feel like I'm 80. I'm only 45. Weight gain. A lot of people say before, I could lose weight like that. Every time, I'll just change my diet, I'll just exercise, and then I could lose the weight. But they're not changing what they're eating. They're actually exercising more. They're watching what they're eating, but they're just pounding on the weight. That's FSH related. The engine is slowing down. Metabolism is slowing down. Estrogen is low. FSH is high. You're just gaining weight rapidly, actually. People really come to me scared that something is wrong with them because they're gaining weight rapidly. How about loss of motivation? I already talked about that. People don't feel like doing anything. They don't want to go out. They want to do anything. Heart palpitations. I had a patient who was seeing a cardiologist. She got an echo. She got an EKG. She got all these tests done. And all it was I checked the FSH. FSH was super high, and that's because of all her problems. So menopause is a big deal. It's very and the amazing thing is you don't have to have stopped your periods to experience these things. So there are women who are still having a period every month, having these symptoms, and so they're confused. They're like, I know I'm not in menopause. I still have a period every month. Why am I having these symptoms? That is that perimenopause phase, that transition. And I tell women, you know, this transition or menopause can last 10 to 14 years, especially in African American women. It can last 10 to 14 years. So think about that, because some women are like, I'll just, work through it. I'll just let it run its course. So as long as you're aware that running its course is not 1 year, it's not 2 years. It could be 10 to 14 years. I want us to make sure that we are aware of that. I already talked about this. So by the time a woman comes to me with these symptoms, I'm checking labs. What's your FSH? What's your estrogen? What's your testosterone? There was actually a patient that I thought, was perimenopausal, but when I checked her labs, her numbers were not too bad, but her thyroid was very high. So she was hyperthyroid. So sometimes it might not be a hormonal issue, it might be a thyroid issue. High thyroid can cause palpitations, hot flashes, irritability, anxiety. So we got to make sure we're checking a full panel. I always make sure I check a full panel on everybody that comes, so I don't narrow the focus too much into hormones. I make sure I'm ruling everything else out before we focus on the hormones, the ovaries as the cause of their symptoms. There should be three categories. Yeah, three categories of symptoms that happen with menopause. The ones I just described to you right now, the hot flashes, sweating, irritability, some people, depression and anxiety. I actually had a patient that was admitted to the psych ward. She was so depressed, so low, had suicidal thoughts, was admitted to the psych ward. But nobody combined that with the hot flashes, the night sweats, the sleep problem. She could not sleep at night. The sleep, nobody combined that together. So after she was on all these psychotic medicine, she was discharged. She was talking to she was talking to her family member, saying that she has all these symptoms of hot flashes, night sweats, and her mood is still bad. And that family member was a patient of mine and told her to come and see me. Once I treated her menopause, she came off her psych meds. She said, wow, she did not even need to be admitted to the psych ward if somebody had just put those symptoms together to know that it was menopause. So the vasomotor symptoms, we'll shorten them, call them VSM. Those are the symptoms of hot flashes, sweating, depression, anxiety, irritability, loss of motivation, sleep issues. Those are the vasomotor symptoms. Now, another very significant category of symptoms with menopause is genitourinary. So that's the vulva, the vagina, the bladder, sometimes the anal area as well. They also need estrogen. Those areas suffer a lot as women transition and do not have enough estrogen in their bodies. And so we'll talk about what those symptoms look like. And then the third part that is very significant is also sexual dysfunction, where loss of sex drive, no interest whatsoever. And this creates the significant issues in relationships because the woman does not know it's menopause. The husband does not know it's menopause. And there's, probably anyone who's in a relationship in a long time, there's context, there's maybe some issues, and those issues become magnified because intimacy has been interrupted. And so it's a big, big deal, the sexual dysfunction part that menopause highlights. All right, so we talked about vasomotor symptoms here of menopause. Then we'll go to the labs that we get. Now, genitourinary symptoms, we call them vulvovaginal atrophy. Vulva is vulva, outside is vulva, inside is vagina. So outside and inside thinning. Atrophy means thinning of the tissue. So when you were young, you had a lot of estrogen, the tissue was plump, it was bouncy, it was thicker, Sexual intercourse was not painful because it could tolerate the trauma. But now, without estrogen, the tissue is thin, easily bruised. There might be bleeding after intercourse because the tissue cannot handle the trauma that happens with intercourse now. The tissue does not have the support that it used to have. Some patients would describe a sandpaper feeling during intercourse, friction, sandpaper sensation. So it's not pleasurable, it's painful. They're bleeding after intercourse, and then the woman just loses interest. It adds to the loss of interest with intercourse. How about urinary urgency? I had a patient, she'll be in the middle of a conversation with somebody at work, and she'll have to stop the conversation and rush to the bathroom. Like, people don't need to know you gotta pee, but this is what women have to deal with as they get into menopause, where they're, or before they leave the house, they pee. When they get to where they're going, they pee. Before they leave where they are, they pee. And then immediately they get home, they pee. Like there's just a sensation of I gotta go, I gotta go, I gotta go. And sometimes you do pee, but sometimes there's only a trickle. So you're like, why was the urgency so intense? And it's only like these few drops of urine that came out. It's loss of estrogen in the bladder. Bladder also needs estrogen. What about frequent UTIs? Patients who have urinary tract infections or bladder infections after intercourse. There's not as much lubrication. There's dryness in the vagina. People are not the women, the estrogen is not lubricating the vagina or lubricating the bladder. And so there's exchange of bacteria during intercourse. Bacteria will stick around, enter the bladder, cause a urinary tract infection. That also makes women not want to get involved, not want to be sexually active. They're getting irritation after sex. They're getting pain with sex. They're getting urinary tract infections after sex. Just makes it too burdensome, right? And so also fuels the loss of interest. There's a patient of mine who came and all she had was vaginal burning, like it's burning. So her general doctor treated her for yeast infection. Yeast infections is like she's taking multiple yeast infection medicines, or they test for it and there's no yeast. It's just a burning or an itching. And the woman has scratched, and with the scratching, she has caused lacerations, little breaks in the skin. Remember, the tissue is thin. So the tissue is now breaking, is now tearing, burning when they pee, burning when they put tissue on. Just a lot of trouble, that happen with this loss of estrogen. And these do not have to happen when your periods have stopped. Imagine you still have to wear a pad, but there's dryness, right? And so there's a pad on for 7 days of the month against tissue that is thinning. So lots of burdensome issues that women deal with loss of estrogen. This is just, a technical term for genitourinary syndrome of menopause. It's progressive, vulvovaginal, meaning the outside and the inside. It is sexual. Bladder, lower urinary tract, that's the bladder. And it is a clinical state of hypoestrogen. So a clinical state of low estrogen is this genitourinary symptom. It can also happen in premenopausal women. So women who have not gone through menopause, it can happen. Apologies. And it can happen in 40 to 54% of postmenopausal women. Women are also living longer. And so the population is going to be about 17% of the population will be over 65 by 2030. And so more and more and more and more portion of the population are going to be presenting with these symptoms. So that is why menopause should be of great interest to clinicians. That's just the point of this slide. Well, I talked about these symptoms already. Pain with sex, vaginal dryness. You're not, and sometimes, I'll talk about it in the sexual dysfunction part where the woman does not have enough time to get there before her partner is ready to go. And so she doesn't have as much time to lubricate before her partner is ready to go. So then there's just a disconnect. And so the partner cannot wait. The woman is taking too long. There's a disconnect there with intercourse. It causes a whole host of issues with sexual issues in the home. I talked about postcoital UTIs or UTIs after intercourse, recurrent bacterial and yeast infections. Every time they're like, I just treated a yeast infection 2 days ago. Why am I having itching and discharge again? Estrogen helps to maintain the pH in the vagina. So let's say you have your period, you use your normal tampons, everything discharge, odor goes back to normal. But women who are in that perimenopause, losing estrogen, start to notice that persistent odor, persistent itching, persistent infections. Every week they're going to the doctor or calling the doctor for yeast infection medicine. It might be a sign of vaginal dryness. It talks about vaginal itching or vaginal burning or pain, or vulvar itching. That's the itching on the outside. The cause is low estrogen. I went over this already. And the treatment, I can talk about other forms of treatment, but standard of treatment, since the cause is loss of estrogen, standard treatment is to give estrogen back. And I wanted to give a caveat here, or a notice, maybe not a caveat, but a notice that vaginal estrogen has not been shown to cause cancer. And I'll get to hormone therapy because I know that a lot of women are afraid when we talk about hormone replacement. So I'll talk to, about that and address some of the fears and provide other options outside of hormones for those women who maybe still want to steer clear of that. So it has not been shown to cause cancer. This is vaginal estrogen. Now we're applying estrogen to the vaginal genital area. I'm not talking about estrogen tablets or estrogen patches. And now new studies have shown that it is safe to give women who have a history of breast cancer. Before, we used to stay away from estrogen from those women and give them medicines that will kill off estrogen in their body. Imagine how much suffering they experienced because of that. So new studies came out, people tested, does vaginal estrogen really bring back their cancer? And they found that it does not cause a recurrence or increase their risk of a recurrence. So now the oncologists, the cancer doctors are getting a little bit more comfortable giving vaginal estrogen to breast cancer survivors. It's still, they're all very nervous about it, but this is the new recommendation. Sexual health. Why do women lose interest in sex? I kind of went over this already. But one of the biggest things is they lose testosterone. A lot of people, when I talk about testosterone, say, isn't that for men? Yes, the dominant hormone in men is testosterone. The dominant hormone in women is estrogen. But women have testosterone, men have estrogen. So the important thing is, what is the dominant hormone? So we have estrogen, that's why we have breasts, that's why we have all the other parts of our bodies. Men have testosterone, that's why they have testes and things like that, and they make semen or sperm. But women have testosterone. What is the role of testosterone in a woman? Sex drive. Testosterone is highly, highly important for sexual desire. And so even women in their 30s, when they come to me and they're either newly married or getting married and they don't understand, they love their partner, but they just have no interest whatsoever. First thing I check is testosterone. So it's not just a male hormone, it fuels sex drive. Also, it helps with energy. It helps with energy. If you're tired all the time, fatigued all the time, you just can't get this, not as quick as you used to be. It could be a testosterone problem. Motivation. You used to be able to work out all the time, but now you can't work out like you used to. Or when you work out, you recover faster. Now it's taking too long to recover. You work out on Saturday, your muscles are sore until the next Saturday. So you can only work out once a week because of that. One of the symptoms of low testosterone could also be that brain fog and also sleep quality. Some people, it's not the hot flashes waking them up. So when someone has a sleep problem, I'm asking them, is it falling asleep or staying asleep? If they say it's both, or then I say, is it what's waking you up from your sleep? Some people, they just wake up and then their mind is just racing about all the things they have to do. And then maybe they're like, getting anxious about not doing all the things that they have to do. That's a testosterone deficiency issue, a quality of sleep issue. And also capacity for people, mood stability, being able to have the patience you used to have for your children or the patience you used to have for your partner could be a low testosterone issue. It might not be because of what your partner did the day before. It might be low testosterone. Um, this is a big one. It's not necessarily related to menopause, but it becomes more prominent as women get into menopause. So stress urinary incontinence. Incontinence means bladder leakage. So not being able to hold your urine, or it could be that urgency, you have to go now. If you don't go to the bathroom now, you are going to pee on yourself. That's called the urgency incontinence. This one is stress, and the urgency incontinence is caused by the genitourinary syndrome of menopause, which is due to the loss of estrogen in the bladder. This one is actually due to the pelvic floor. Any woman who's been pregnant, any woman who's had vaginal deliveries, any woman maybe they had to use forceps or vacuum to get the baby out. Those muscles in the pelvic floor used to support the vagina and the bladder. You remember, pregnancy is 10 weeks. I mean, 10 months. So that's 40 weeks. Constant, gradual, progressive pressure on the pelvic floor for almost a year. And then if you have a vaginal delivery, you push that baby out, you stretch out those muscles some more. And so those muscles that used to hold up when you bore down, let's say you're bearing down to cough, sneeze, you're bending down to pick something, those muscles will hold up and support your bladder. But if they've been stretched out, if they've been through vaginal delivery and pregnancy, those muscles give way and then the bladder leaks. Those muscles are supposed to hold up your bladder, but once they've been affected, and pregnancy multiple times. Women are pregnant more than once. Women are birthing more than once, right? General. And so constant tearing of those muscles, constant wearing out of those muscles. Every time you cough or sneeze, the pelvic floor gives way, the bladder leaks. So that's what we call stress, meaning you're putting stress down, urinary on the bladder, incontinence, you're leaking. And so menopause makes it more pronounced. People are like, oh, when I had all my kids, I didn't have this problem, but now I'm 55 and suddenly it's more prominent. I have to wear a pad. I had a patient who had to wear a pad all the time. She was so depressed because she felt like she smelled like urine all the time, having to wear a pad. She was so it affected her confidence. So these things are a big deal. You know, they might happen to people immediately after childbearing. Some people, they don't have those symptoms until they get into that loss of estrogen part in the vagina, and it becomes more prominent. Talked about this already. Involuntary leakage of urine affects nearly 40% of women. It impacts quality of life. It affects the physical, mental. So, I mean, if you're wearing a pad, you think you're smelling of urine, you might not want to hang out with your friends after work. You might just want to go home, take a shower, and be in your own space. It affects it causes social isolation. It's a big deal. Now, treatments. I'm sure you guys want to know, what can I do about this? I'm tired of dealing with it. What can I do about it? So, vasomotor symptoms of menopause. Those are the hot flashes, the night sweats, the mood irritability, all the other stuff. Some people just want to know natural stuff. What can I do naturally on my own to get rid of these hot flashes? Um, Exercise is a big deal. I have a patient, she refuses hormone and she exercises very regularly. And so basically you are the one maintaining that FSH level, keeping that FSH at bay by increasing your activity level. But people work 9 to 5. People have children to take care of, kids to pick up from school, homework to help with. Maybe you don't have that time to work out 5 times a week, right? Keeping cool. You'll see women with a fan. Handheld fan is popular now. Or their room during the winter, the doors are open. You guys are in Texas. I don't know how you do it during the during the winter. Maybe the air conditioner is on during the winter or something. So keeping cool, because the symptom is heat. So excessive heat, non-regulated heat. That's that FSH issue, dysregulation of the body temperature. So I have a patient who, once it starts coming, she drinks a glass of cold water and the hot flashes flash away. So there are people who are able to manage their symptoms with a lifestyle. Maybe that lady who can drink cold water when the hot flashes come on, her FSH is maybe 35. But maybe your FSH is 105. Cold water is probably may not be enough to make that hot flash recede. I had a patient who said to me that when that hot flash comes on, she gets this feeling of doom. Like it's like a cloud of doom washes over her. She gets so depressed. She gets feelings of, what is the point of living? That is how significant hot flashes can be on someone. So not just I'm getting hot, I'm wearing a fan. They can be very severe in the feelings that accompany them. People who maybe had depression before, well managed, suddenly they get into menopause. They can't, the symptoms are, the psychiatrist is increasing their medicines. They're not able to cope like they used to. I hear that a lot, not able to cope like they used to. That could be a perimenopause, hormones are declining, things that may be, they become just more prominent as the hormones decline. So there's a lifestyle and there's the non-hormone medications. Now, let's say for a patient doesn't want hormones, having hot flashes, sweating, those hot flashes and sweating are keeping her from sleeping, and therefore she's tired all the time and irritable. Okay, the non-hormone medicine is usually antidepressants, like an Effexor, but we're not using antidepressant doses. We're using lower doses than antidepressant doses. So it's not like people will see it and say, Doc, you gave me a medicine for depression. I'm like, yes, it's an antidepressant, but it's not for depression. It's for hot flashes. The doses we're using are doses for hot flashes. So lower than what a psychiatrist would prescribe. And they help to tell that FSH to calm down. They work at the level of the brain, telling the FSH, calm down, you don't really need estrogen, stop pumping out FSH. And so FSH gradually declines, and then hot flashes are not as severe. They're able to get a good night's sleep. They're not as irritable in the morning. So that's for women who maybe the vasomotor symptoms are the biggest symptoms for them. Now remember, FSH is high because it wants estrogen. So if we give the body hormone or estrogen or any other hormone, then FSH will back off because basically FSH goes up so that your body will release estrogen. But FSH goes up, it doesn't see estrogen from the ovary. It goes up, doesn't see estrogen from the ovary, keeps going up. But if you give it estrogen, FSH will come down. And so that's why we get into the hormone medications. Now, before I go further into the hormone medications, I want to maybe allay some fears that people have about hormone replacement therapy. When they did the study, it's called the Women's Health Initiative, WHI study, for hormone replacement. They had a wide range of women and age-wise. And their goal was, we know that estrogen protects the heart. Estrogen, women who go into menopause early have an increased risk of heart attack. So it's important. Menopause, estrogen is protective. It has significant impact on the body. So if you see a woman in her 50s going through a heart attack, she probably went through menopause early. Women don't usually experience those types of things until 60, 65. You might see more earlier in men, when men in their 40s are having heart attack, but not generally women, because they have estrogen for a long time, up until 65, to protect them. So the study was looking at, can we give women proactively estrogen so that we just reduce their risk of heart attack in general? So they gave them estrogen tablets. But if you give a woman estrogen, remember what estrogen does to the uterus? Estrogen stimulates the uterus so that you have a period. So let's say this woman is in menopause, not having periods anymore. You give her estrogen, she's going to have a period. And women get upset about that. They're like, I thought I was done. Now I'm getting periods again. So to counter that, you have to give them progesterone. So in that study, women had estrogen tablets, progesterone tablets. And they gave it to women of all ages, in their 40s, in their 50s, in their 60s, up to age 65 and above. Then these women in their 65 and above started having heart attacks. More heart attacks were happening, more strokes were happening. They found more breast cancer. And so they rapidly stopped the study. Black box warning. Everybody got scared. Nobody wanted to use hormones anymore. So for a long time, hormone replacement therapy had a bad rep. What was happening to women in those times? They were suffering, suffering. Imagine having a full-time job and sweating through a meeting, and having to explain to the people at work that you're not sick, you're just going through menopause. You just would rather not have those conversations. So what have we done in the meantime? We have switched to estrogen patches so that you do not have to take an estrogen tablet by mouth. They found that the cause of the issue was that estrogen was being broken down by the liver into these metabolites. These metabolites would increase clotting factors and cause more blood clots, stroke, heart attack, things like that, and more metabolites that can increase the risk of breast cancer and maybe somebody that it might not have been triggered in to begin with. So they found a way to give estrogen without going through the liver. So estrogen patches. There'll be things like combination patches. So if you still have a uterus, you get an estrogen progesterone patch in one. And that way it's not the tablets being broken down by the liver, and your risk of those side effects are less. They're not zero. We cannot promise anything with medicine. They're less. Are there women we find breast cancer who are on HRT? Yes. The point of hormone replacement therapy is that you are with a provider. You're with a physician who's watching you, who's giving you the lowest, most effective dose. We don't want women on birth control, women at 65 on birth control. Those are high doses of estrogen. They don't need that. They need the lowest effective dose. The small amount of estrogen that will get the FSH to back off, small amount of progesterone that will protect the uterus and not allow them to have periods or abnormal uterine bleeding. So we found estrogen patches that way. The novel invention that I believe is the way of the future is testosterone. This is because testosterone will take care of all the vasomotor symptoms, everything possible that menopause, that FSH is causing. Testosterone will counter it. The hot flashes, the sleep issues, the irritability, the energy level, that fatigue, that loss of motivation, testosterone handles all that. With the added benefit of increasing your sex drive. I have women who come to me already seeing a good doctor. The doctor is giving them estrogen. They're not having hot flashes anymore. They're sleeping well. Everything is going well, except their sex drive is still low. It's still affecting their relationship. They're sleeping well, they're not irritable, they're not in a bad mood, they still love their partner, they just have no desire whatsoever. But testosterone will give you your sex drive, your energy, your motivation, your endurance. My patients will tell me that now when they exercise, they recover faster. Plus the added benefit of all the problems of estrogen deficiency. Now imagine a woman with genitourinary symptoms, right? She's having dryness, the tissue is thin. Like I was saying before, the husband is ready. She's not ready because she needs more help to get stimulated, to make lubrication. Testosterone probably speeds that up within 5 minutes. And so the woman is as ready as a husband, can lubricate just as fast. And maybe she doesn't need to be using moisturizer. She doesn't need to go grab a lubricant right before sex. Some patients would say that that ruins the mood, right? Because they have to stop, go grab a lubricant, and then the mood is lost. Or if their partner is dealing with erectile dysfunction and there's only an erection for only a short period of time, and you're using that time to grab a lubricant. So it can be quite disruptive. So the advantage of testosterone is that it gives the woman the sex drive, energy, sleep, better mood, and same sort of level, not completely. Actually, some of my patients are the ones initiating sex with their partners. I have partners who complain that the fact that they have to initiate it every time makes them feel like the woman is not really interested in them. So sometimes I'll see male patients getting to give them testosterone and they complain that the fact that they have to ask for it every time makes them feel as if the woman maybe doesn't find them attractive anymore. He's not even thinking about it. And so it begins to affect their self-esteem and their security in the relationship. These are major, major issues. So if the woman is now the one with the sex drive initiating it, it fuels his confidence, makes him feel like, yes, we're having a thriving, intimate relationship. She's attracted to me. This is great, right? So that's what I found to be the advantage of testosterone over all the other hormone therapies. And then testosterone can be given by cream or by pellet. So no tablets, no patches. It is avoiding the liver altogether. It's been around for 40 years and has not been shown to cause any cancers, heart attack, stroke. It can also be given to women who have had breast cancer in the past. Testosterone is converted to estrogen in the body, but it maintains menopause level estrogen. The problem with the WHI study was that they were giving women pre-menopause estrogen levels that was not causing problems for their hearts and causing problems for their blood vessels and things like that. So that's the advantage I found with testosterone. With estrogen, there's you cannot give them anyone who has liver problems or kidney problems. You cannot give anybody with gallbladder problems. You cannot give anybody with a history of breast cancer. You cannot give them estrogen patches or creams or except vaginal. Um, and then when you get to 65, you have to start talking to them about coming off the estrogen because remember, in the WHI study, the estrogen created problems in women over 65 and up. So when they get to 65, you have to start asking them, okay, we have to start weaning you off. And that can be very disruptive. A woman who's not used to hot flashes, who's used to sleeping well, suddenly you stop her estrogen, her life goes down. But there's no age limit for testosterone. Women in their 70s, 80s can get testosterone because it doesn't cause any of those things that we worry about with estrogen. So I am an advocate for testosterone. I liberally give it. I dose it based on labs. So most women, even women in their 30s, as early as 38, are coming to me. They don't have hot flashes, they don't have anything, but they have no sex drive. I check their testosterone. Testosterone should be maybe 60, 70, 80. You're seeing testosterone of 3, testosterone of 5. And just giving them a testosterone booster or pellet or cream fixes the issue. So highly, highly is one of my biggest options I give people. Again, there are people who don't go for it. They go for exercise, and that's okay. But if you have a profile of symptoms that includes low sex drive, sexual dysfunction, vaginal dryness, testosterone is one treatment instead of taking 3 different things. Now, for the genitourinary symptoms, because there's loss of estrogen in the vaginal area, bladder area, in most women, I will recommend putting estrogen directly in the vagina. Remember my little notice at the beginning? vaginal estrogen. I'm not talking about estrogen tablets or estrogen patches now. Vaginal estrogen has not been shown to cause cancer or bring back breast cancer in women who have had cancer in the past. It's also not enough dose in that estrogen to stimulate the uterus and bring in periods. So it's if you give estrogen by mouth, by injection, that can go to the uterus to stimulate the uterus and cause a period. We don't see that routinely with vaginal. It's like you're putting cream on dry skin. That's what we're doing with the vaginal estrogen. So we don't see a lot of systemic absorption. It doesn't really go into the body and cause issues on average in general in most women. The bladder symptoms of leaking urine with coughing or sneezing. Remember, it's a muscle problem. So those muscles have been stretched out. Any muscles you want to make firmer, you want to make stronger, you work them. So that's this pelvic floor therapy. You work those muscles, make them stronger. So it's something called, you go to a therapist. She's a pelvic floor therapist, not just a physical therapist. And she does exercises that build up those muscles in the vagina so that you can get control of your bladder back. For that urgency, I have to pee, I have to pee, I have to pee. One of the questions I ask my patients, or one of the list of questions I ask my patients is, what's in your diet? Caffeine, tomatoes, citrus, oranges, lemons. I had a patient who said she's not getting enough sleep at night. She's waking up 2, 3 times a night to go to the bathroom. And so I was like, are you drinking a lot of water close to bed? She's like, not really. I just eat these little tiny cuties. I was like, what are cuties? She said they're oranges. I'm like, that's why you're waking up 3 times at night to pee. The citrus in the oranges is causing overactive bladder. And so we had been talking about vaginal estrogen, and I was like, you know what? Cut out the cuties and see. And that's all. And she wasn't even in menopause. She was like in 38, 39. And so what's in your diet? And as you know, a lot of Africans, we eat a lot of tomatoes. It's in our stew, it's in our soups. So something to think about. You might have to make a different soup for yourself and for the rest of the family if you don't want to do estrogen or hormones vaginally. Now, I liberally give vaginal estrogen because of the new studies that show that it doesn't cause recurrence of breast cancer in women with a prior history. So it has a pretty good safety profile. And it allows you to enjoy your caffeine, allows you to enjoy your tomatoes and citrus without the urgency sensation. It also builds back the muscle of the tissue. Builds back the tissue of the vagina. Remember, the tissue is thin, dry because it's lost estrogen. Estrogen back in there gives it its strength, gives it its bounce, its thicker tissue back. Now, I had a patient who had breast cancer in the past, suffering with vaginal dryness. There was nothing I told her about vaginal estrogen that she would hear. And I did not blame her because who wants to take that kind of risk? And so I was like, what can I give this woman to help? Because it was affecting her relationship. Sex was painful. She did not want to be intimate with her husband. She was bleeding after intercourse. The tissue was so thin. Sometimes even trying to do her physical exam, I have to go and find the smallest speculum because it was becoming narrow. That area becomes narrow as we get older, especially if we don't do anything. The vagina becomes narrow, thinner. Your pelvic exams are going to be harder to do. Your pap smears are going to be more painful. So it's important to treat unless your symptoms are not bad. And so what I found for this lady was vaginal laser therapy. And I have a video, I believe, here that will show you how it works. I talked about hormone replacement already. Let me go back here. I'll show you how vaginal laser works. There is no hormone with vaginal laser. So it's perfect for women who don't want any hormones. What the laser is doing, it's like a little ultrasound probe that goes in the vagina. And then I press the foot pedal and I push the laser treatment in the vagina. And the body is getting a signal that there is an injury in the vagina that it needs to go and repair. So the body will send all the repair mechanisms to that area and begin to repair it. Remember, if you have like a cut on your skin, and then over a few days it becomes a scar, the body has repaired that cut. That's what the body is doing inside the vagina. So that's what the laser is doing, is stimulating cellular repair at the cellular level. And so new glands, so you start lubricating on your own without having to put in estrogen in there. Collagen, the tissue gets stronger. So those women who used to suffer with the leaking, where the tissue was worn, the tissue, the pelvic floor tissue gets stronger. The women who bleed with intercourse, because the tissue is so thin, there's now bounce back because of collagen, thicker tissue. And more nerve endings. Remember, it's making it like new. It's repairing it to its original state. And so a lot of women describe more sensation with intercourse. So the laser goes beyond just treating the vaginal dryness or the bladder issues. It actually improves sexual experience. So I'll get there. So I was talking about hormone replacement therapy. Testosterone is bioidentical. What does bioidentical mean? It is it looks like our own natural hormones. It is made from plants. The plant is cassava yam. I don't know if you guys remember, but twins are, I'm a twin myself. Twins are popular in Africa because we eat cassava yam. Cassava yam has estrogen and testosterone. So they have hormones. Plants have hormones. So they harvested the testosterone and estrogen from these plants and then made them into creams, pellets, troches. There's some that they dissolve under the tongue. They make a lot of things. But I didn't want to be doing too many things. So I chose the cream and the pellet, and I'll show you what the pellet looks like. And what do the pellets do? They're inserted in the body, small incision, very small. You don't need stitches. You don't need downtime. You don't need to take time off work. The pellets are inserted inside the body and they dissolve over time. So it's like powder that they made solid. Let me see if I have a picture right here. Literally looks like that. That's how thin it is. That's testosterone, that's estrogen. Estrogen is smaller, testosterone is bigger. And it is inserted in the body. We're trying to copy the way your body used to give you hormones. So the ovaries will release it into the fat cells, then it will go into the bloodstream. So we are putting the hormones in the fat cells, and then it's released into the bloodstream. Advantage of the pellet, you don't have to do anything every day. The cream, you do have to apply it on every day. And you will notice a difference on the day you don't put it on. You might have more hot flashes that day and things like that. But remember I said testosterone can take care of all the issues of estrogen, plus the added benefit of increased sex drive. And so some women, all they get is testosterone. Like I said, has not been shown to cause breast cancer, uterine cancer, no cancers whatsoever, no heart attack, no stroke, because it's not taken by mouth. It's not a tablet, right? It's either a pellet or a cream. The cream you apply on the inner part of your forearm or inner part of your thigh or inner part of your elbow. You have control over that. You determine how much you get. If maybe the sex drive is too high, becoming disruptive at work, you're thinking about sex all the time. Okay, maybe you can back off on the testosterone cream to 2 pumps instead of 3, instead of 4. With the pellet, it's dosed based on your labs. So how high is that FSH? How low is that testosterone to determine what your dose is? And then it can last you 6 months. I have women who only come to me twice a year. They get their pellet, I see them again in June. They get it in January, I see them in June, then I see them January next year. Maybe some women only come to me for this. Now, their pap smear mammogram, they get it done regular gynecologists, but they come to me for their feel good. They call it their feel good hormone. So what is my point of all this? Hormone therapy can be given in a safe way. There are non-hormonal ways to treat the symptoms, depending on what the most bothersome symptoms are. If a patient is not in a relationship, does not need high sex drive, but suffering from hot flashes, okay. She doesn't need testosterone. She doesn't need estrogen. She can just get the antidepressant medicine or the other medicines that calm down FSH. But if the symptoms of hot flashes, night sweats are associated with sexual dysfunction, then it's time to talk hormones. There's no other way to make your sex drive better aside from testosterone. So that's the point of that. That's why I spent a lot of time on the hormone therapy. There are safe ways now to give hormones. That's the point. All right. Oh, the laser. I wonder if this video will play. Let me give it a try. All right, this is the Feminine 15 CO2 laser for vaginal atrophy. People have been asking me how it works, so we're going to create a video to show you guys how it works. It's for women who have vaginal dryness, urinary incontinence, frequent bladder infections, frequent urinary tract infections, frequent vaginal infections, and cannot use estrogen. So this is our alternative for them.
machine is preparing the probe.
So that's the probe that goes inside the vagina.
Well, we can call it the time machine.
Time machine, yeah.
Yep. Yep.
This is the probe. It's an ultrasound probe. It looks like an ultrasound probe, rather. So no needles. You don't need any anesthesia. We just put this inside the vagina, set our settings on the machine, press a foot pedal, and get a beep. And then we turn it, foot pedal, beep. Turn it, beep. Turn it, 360. Okay? And then we pull back 1 centimeter, press the foot pedal again. And then we turn it all around 360. So we keep coming out 1 centimeter, turning around 360 until the vaginal canal is treated. Okay. And that's it. It's like 5 minutes. That's the whole treatment. We're offering it at Dardur Gynecology. So come on in. All right, that's the laser machine. One of my favorite procedures to do. It's just the transformation, the feedback when the women come back. Remember, it's at the cellular level, repairing the vagina, telling the brain, oh, there's some injury there. So it's sending all these good stuff that will give the new tissue, new glands, new nerves. So the increased sexual pleasure was actually something that people started telling me I was using for dryness. I was like, instead of estrogen, let's use it for dryness. And then they'll say, oh, I noticed more vaginal orgasms, increased sexual pleasure, more sensation because you're getting new nerve endings in there. So very, very important. Also for that stress urinary incontinence, it makes those muscles stronger. I actually have had maybe 95% success rate of curing. I'm going to use the word curing stress urinary incontinence, meaning a patient came to me at the beginning, stress urinary incontinence. I always offer 3 treatments: vaginal estrogen, pelvic floor therapy, vaginal laser. Maybe they don't want hormones. Pelvic floor therapy requires them to go to a therapist every week for 12 weeks versus the treatment, the laser, that's once a month for 3 months. She chose once a month for 3 months. She comes back after month treatment 3 and tells me there's no more leaking. I can jump. I can go to the gym. I don't have to wear a pad. I don't smell like urine anymore. Boost your confidence. If you're in a relationship, you're in a marriage, you have a sexual relationship, there's more sexual pleasure. Boost your confidence. You're going to want to be sexually active with your partner. You're going to lubricate better. You don't have to go grab a lubricant, right? And so the laser has become very popular in my practice, even for young girls who maybe they've had 3 kids and they're only in their 30s and they're like, why do I feel like I'm in my 50s? I'm leaking urine. I have to wear it depends. I'm only 35. Vaginal laser is a good option for those women. All right. Oh, I already talked about all this, how it works. The video kind of told us that more nerve endings, so better sexual experience, more glands, so more lubrication, thickened vaginal tissue, so it's not thin, it's not bruised, it's not bleeding after sex because of the microscopic injuries that cause a healing cascade, healing process to happen in the vagina. It can last you about 2 years, actually. So as we get older, things continue to age, so that repair will wane out, but at least it lasts about 2 years. The younger girls may not experience that as much as the older ladies who maybe are now really menopausal and need that maintenance once a year after that. I've had complete resolution. I would say 95% of patients instead of 90. I've had more results, more data that, 95% of my patients have complete resolution of their stress urinary incontinence, improved sexual satisfaction, increased vaginal tone, and helps that overactive bladder sensation. Oh, I have some patients' story. So this patient just had a baby, recovering from her delivery. She's sleep deprived, waking up at all hours of the night. She's breastfeeding. When you're breastfeeding, there's a hormone called prolactin that the brain will release. That prolactin will tell your ovaries, don't ovulate, don't make estrogen. We're currently breastfeeding, don't get pregnant. What happens when you have low estrogen? Vaginal dryness. So you have a woman who's breastfeeding, recovering from delivery. A husband, maybe they've not been sexually active during the pregnancy. Now she's delivered. It's 6 weeks later. She's healed. They still can't be sexually active because she's uncomfortable. It's dry. So you can see how frustrating it can be for young couples who just had a baby. And so this lady didn't want anything to affect her milk coming down. She didn't want any hormones, even though I told her vaginal estrogen will not do that. She chose the laser. One treatment per month for 3 months, life is changed, right? It's not hormonal, does not affect the breastfeeding. Now the vagina is healthier, even if the even if the ovaries are not making estrogen, the tissue is treated, right? Um, so that's the advantage of the laser. This patient of mine actually had like five children, very busy life, very, very busy life. Full-time job, 9 to 5. Babies that were under 5. She had twins under 5. So I think they were about 3 or 4 when she came to see me, 3 or 4 years old. Two kids under 5. And then the other kids were in high school. So the activities, homework, PTA, plus her 9 to 5 job. And then her husband also demanding her attention. She just felt like she was being pulled in 100 different directions, and she just could not have capacity to handle it all. Treatment plan, this lady, I checked her hormones. She was not in menopause. She's still having periods every month, but she felt like she was. She got testosterone. She's been my client for over 4 years now. She sees me every 4 to 6 months for her testosterone. Her husband is the one that reminds her, oh, I think it might be time to go see Dr. Durowade for she's almost signaling that I'm starting to notice some snapping from you or some irritability from you. Maybe it's time for your hormones. Um, and the thing is, it's not that your body's not making testosterone, it's giving it up at the expense of the estrogen. There was a woman I met, you know, she may be in her 50s, early 50s, and I was asking all these questions, any hot flashes, any mood issues, and she said, no. And the first question I asked her is, what do you do for a living? She said, I don't work. So I like those are the women who don't have low testosterone. They can sleep till they want. They no financial struggles. Well taken care of women. They're the ones that don't have low testosterone. So in general, most women are busy. Children, job, family, husband, maybe extended family, parents, taking some women are taking care of their parents. So very, very busy life. Testosterone will take a dive at that time because the body nature wants to maintain fertility. And so giving back testosterone reminds the body that, okay, you two need energy, you two need sleep, you two need sex drive, you two need intimacy with your partner. So I'm a big advocate of testosterone. That's the whole point of that. Oh, this patient of mine, this is the last one. This patient of mine, um, you know, she had a 5-year-old already and a 12-year-old already, and she was trying to decide, oh, maybe do I want another baby? And then spontaneously got pregnant with another baby. After the 5-year-old, she had stress urinary incontinence, leaking with coughing or sneezing. And she had been thinking about the laser, but she wanted to wait to see if she got pregnant again with another baby so that she would do the laser after this baby. But she did pelvic floor therapy after the 5-year-old. Her symptoms got better. With pelvic floor therapy, you have to keep doing the exercises. After the 12 weeks is over, you don't just stop the exercises. The muscles will get weak again. So she was able to keep up the exercises until she got pregnant again, had another baby, and got very busy, and not able to continue the exercising. And remember, she has strained those muscles that she worked before. She has strained those muscles again, 10 months of pregnancy, pushing out the baby, those muscles just gave way. So and she owned her own business. So, it's not a 9 to 5 when you own your own business. It's 24 hours, 7 days a week. So when you say somebody was overwhelmed, it was this lady. But we solved her problem with testosterone. So we did all three. She got bioidentical testosterone for her sex drive. She got pelvic floor therapy because she had stress urinary incontinence before this baby, and then it worsened after this baby was born. So pelvic floor therapy is once a week for 12 weeks. Laser is once a month for 12 weeks. So in between her pelvic floor therapy, she'll come for the laser. By the third month, all symptoms gone, all leaking gone, all dryness gone. Even though she was breastfeeding, remember she's getting the laser, it's giving her lubrication. Felt like she could handle her life. She'll bring her baby to her appointments. We'll chat forever. It's just to have those results, seeing them at the beginning and seeing them at the end of the treatment, just very fulfilling very assuring that, I am transforming women's lives. I'm fulfilling the purpose that I established my practice for. So that's why you find me talking about it on YouTube, Instagram, video, that's why I'm just always talking, because there is an option for you. People would go to their doctor and their doctor said, well, it's just menopause, as if that's how life should be. I personally don't believe that. I believe that you should thrive at every stage of your life, whether you're having kids, whether you're not having kids, whether you're having periods, whether you're not having periods, whether you're perimenopause or menopausal, you should be vibrant. I believe in a vibrant woman. And so that's why I do what I do. So my usual treatment profile is either hormone therapy plus the laser, or hormone therapy plus pelvic floor therapy, or no hormones. You could do all lifestyle. You could do exercise. So I have a patient who's a yoga teacher. So she doesn't have the hot flashes and everything. She's been able to manage those symptoms with strenuous, consistent yoga exercises. But the sex drive, she needed testosterone for it. And so most times you can do lifestyle for the majority of symptoms. When you're talking about sexual dysfunction, you need hormones, specifically testosterone. I have a patient that calls it the feel-good hormone. I feel good about myself. Just overall, I feel good, more self-esteem. They feel good about themselves. All right, this is the name of my practice, Dardur Gynecology. Dardur is my father's name. Dardur Durowade is my father's name. So it's named after him. You can see here that we have 5 stars, at least 193 and counting. We're in Flossmoor in South suburban area of Chicago. I do have patients who fly in from Miami, from Florida, from New Jersey, Philadelphia to see me for these treatments. It's just in and out. They come the same day, they go home the same day. They come from the airport to their appointment, back to the airport, back home. So some people, that's how worth it is for them. That's how transformative it is for their lives. So that's the name of my practice, and I'm in Flossmoor.
So to everyone, I appreciate you, Dr. Durowade, and I appreciate everyone for staying longer. I hope you have been blessed, and you go and have a beautiful you the rest of the day. God bless you.
Thank you.